Hello, everybody. I am Kathleen Yoder, and I'm here today to talk to you about improving the user experience with electronic health records. So Nelson and Staggers tell us that the International Organization of Standardization defines user experience as a person's perceptions and responses that result from the use or the anticipated use of a product, system, or service. For all intents and purposes, our users are encompassing our staff that use our EHR. The main focus is on nursing and physicians since they use it the most, but we must always be mindful that it takes all different disciplines working in a variety of ways in order to make this multidisciplinary record usable. So there are three main factors that influence user experience. We have the usability of a product, the human-computer interaction, and ergonomics. First, let's talk about usability and what it means. So Whitney Queensbury talks about the 5 key elements to usability. Effectiveness. Will this EHR do what we need it to do? Will it house the patient's records, all the information, medications, laboratory results, but will it also provide other things like billing for supplies and services? Engagingness. Is the EHR pleasant to work with? Is it easy to read? Can it be individualized for the user's own workflow? And is it simple things like, is the font easy to read? Is it big enough for the user to be able to see? Is it efficient? Can our users work in one area, or are they going to have to keep switching between multiple tabs in order to get all the amount of information that they need into the computer for one patient encounter? Error tolerance. So as we're increasing our user experience, we also don't want to increase our errors. So this would be things like placing the word pending in a result that's not back yet. So say you drew a CMP, you sent the labs, you log into the computer, you log up the labs, most of the CMP is resulted. The only thing that's not on there resulted is the potassium, and it's just left blank. Well, the user doesn't know if the lab wasn't maybe ordered correctly, or if the lab is still running it. So by putting the simple word in as pending, the user knows that they need to come back because the information is incomplete. Will the program also automatically refresh? So if you're in the EMR, will there be an alert or a flag to let you know that new medications have been ordered and added so that things aren't missed? And then lastly, the ease of learning. How many classes will our staff need in order to learn the new program and changes that we've made? Will the programs be similar to other web-based programs that the employees might be using outside of work? We don't know. But all of these, as the ISO says, contains usability, which is what is the extent of which a product can be used by specific users to achieve specific goals with effectiveness, efficiency, and satisfaction to a specified content of use. Our next factor is human-computer interaction. So what are we going to be using the computers for, and how is the program going to work with us? How are the logins going to work? Who's involved and who's using it? And this actually has grown into being its own field of study, stemmed off of computer programmers. It tends to involve a lot of people. So it's not just us end users that are involved in this, but also the financial backers, the design team, and programmers, just to name a few. And then lastly is ergonomics. This is known as people's efficiency in the workplace. So will the computers be stationary in the room, or will they be portable? Will they force the provider to have their backs to the patient if it's stationary and logged onto a wall? Or will they be standing? Will they be at chair height? Will they be able to go up and down? If they're portable, is the computer going to go in between the patient and the provider, thus creating a barrier? Will there be enough computers even in that area? So say you're in a multidisciplinary team and multiple people are trying to log into a patient's chart and document all at the same time. Well, is the program going to even allow that? Will so many people be able to be in a patient's chart and looking up information? And then will they be touchscreens versus keypads? So there's a lot of usability questions that go into just simple ergonomics with this. So what are our goals for increasing and improving our user experience? Well, we want to increase our effectiveness, we want to decrease our errors, and we want to increase our efficiencies. We would like all the information to remain in the chart, to be orderly, and have access to retrieve it. We want to decrease our errors by putting in simple changes. Examples to this could be discharge instructions printed in multiple languages. And then increasing our efficiency, we want multiple providers to be able to chart on a patient at the same time so that the care is not delayed. We'd like fluidity with orders and charting. What we don't want to do is cause more work to be done and have it take more time. We want the system to help us work smarter and not harder. And then the big question is, how are we going to do all this? How are we going to fix these problems? Well, to start with, when we first initiated our EHR, we began with a user-centered design. So that is what we're going to continue on with. These designs tend to be multi-step, have different phases, and work with it. We're going to continue through a heuristic evaluation on the current electronic record. We're going to pass out usability questionnaires, then we're going to implement our new program into certain test areas, and then finalize it with a comparison testing. So let's talk about the user-centered design that we initiated from the beginning of our EHR. So this begins at the actual build of the users. We use end users in the build so that we, from the beginning, can make our plans as to who is going to be using these programs and tailoring the programs to them. With user-centered design, we use these users early on and then, like now, throughout the process. It takes multiple drafts and it continues to be tailored to suit the needs of the specific users. So with a heuristic evaluation, we're going to have 3 to 5 evaluators and experts that are going to receive training on our electronic health record, and they're going to work through with the tasks that, say, a nurse would do on a routine encounter with a patient. They're going to work independently, and then from there, the experts will compare what they have done with these tasks to an accepted usability guidelines. And then from there, each of the experts will compile a list of violations that they have found that stem off of the accepted guidelines. And then once this is done, we're going to move on to a usability questionnaire. So we sent out one of these usability questionnaires to our staff and just to nurses specifically to see what kind of changes they like to have made. So we found that there's a nurse dissatisfaction. They found like they were doing excessive documentation and the requirements for documentation were getting more and more. Nelson and Staggers tell us that a simple admission assessment intake can take over 500 clicks to complete. There are some patient safety issues. So usually this is a top priority for hospitals as well. Similar to what we were talking about earlier, the nurses were asking for discharge instructions to be able to be printed in multiple languages. They found that they have an ease of use with in-person translators during their verbal portion of their discharge instructions. However, patients were still getting sent home with everything written in English, making them kind of null and void. People have been complaining of alert fatigue. So imagine a postpartum patient is having their medications charted. Every time they go to chart their medication, an alert pops up telling them that oxytocin, which is a routine medication used to prevent postpartum hemorrhage, which any patient that is being followed by a physician who follows ACOG's guidelines will receive this medication for 4 to 6 hours after delivery. But they get an alert saying to use caution with this medication in lactating women. This is a routine medication, but the alert comes up multiple times a day on every patient on the unit. And so the nurses just continue to click through and ignore it, and they may actually be missing alerts for other things, thinking that it's still the same oxytocin alert. So they have found that the programs don't match the user's workflow. Every time the lab goes to log into a patient's chart, it comes into their EMR. Doesn't always have interoperability. So things in the patient's chart should be fluid. We should be able to look into radiology, laboratory, pharmacy programs without any issues. However, say you get a transfer from within one health system, one hospital to another, and now the nurse is unable to log in and see what type of medication was given at a facility that's maybe across town from where they live in, owned by the same company, has the same EMR, but they can't get into that portion of the patient's chart. There's been some simple complaints about design and visibility, and even things as simple as color and it being difficult on the eye, staring at like a bright yellow screen. Weinfeld and Messari tell us back in 2017 that there was some impaired doctor-patient relationships. Patients were feeling like the computer was being placed between them and the physicians, and that they weren't getting the care that they normally would be receiving. They felt like they were getting more information going down to their chart than to them. And with that said, the physicians complained that there was felt that their note writing was more being based on what they could bill the patients for and not actual information that was required for the patient's charts. So after this, we decide what we're going to change and how we're going to implement these things. So we're going to trial them on specific test units, and then we're going to educate the staff. And depending upon how intense and how big of a change is going to happen, either the education is going to have to happen in person, or it can be done as online independent learning. And then everybody's favorite feedback to tell if this implementation is working or not is a mandatory post-education survey. So before you get credit for doing your independent learning or for showing up to that 4-hour class above your hours, you need to fill out your survey and hand that back in as truthful as possible in order to get the best information you can. And then lastly, we're going to do a comparison testing. So what does the new product look like compared to the old one? Nelson and Staggers wants us to compare to see if our objectives have been met, which means has there been increased efficiency, increased effectiveness, and is it more satisfying than the last program? So what does this all mean? Have we been able to increase our user experience? Is it more effective than before? Is it more efficient? Our hopes is that as we follow these steps, we will be able to increase our user experience. Middleton et al. States that the end users of the electronic health records play an integral role in the usability of the applications. And with the user-centered design model that we initiated with our EHR, it's a constantly evolving. So the user experience is the most important portion of this model. We know that using the user-centered design model that it will be a constantly evolving program. So will we ever reach our goals? Maybe, maybe not, because I think our goals are always going to be changing. So we're always going to want to increase our effectiveness just a little bit more. There's always going to be more errors that we want to decrease, and we always want to make our efficiency just that much better. So I think that by using this new plan, we'll be able to increase our user experience, and then we'll build from there and continue on. So thank you everybody for listening. Have a good day.